a link with them. Great, so welcome. We'll do introductions in a moment, but we can set the stage a little bit to start. We're providing a webinar today, calling it Enhanced Linkage to Care, Models and Practices, so welcome. The purpose of the webinar today is to think about and consider foundations of linkage to care services, and also skills that are beneficial and needed to be able to maintain key partnerships, and in order to more effectively reach and serve our prioritized populations. And when we're thinking about this word enhanced, what we're going for is thinking about linkage in a very broad sense. And so we mean not just a linkage to care program per se, a traditional model, but all that makes up HIV navigation services, and also where linkage interfaces and touches our other programs and services so broadly, because we know the community organizations that we've been talking with and done our assessments with have broad needs and aren't just related to linkage, but a lot of what we've talked about sort of overlapped and touched with linkage services. And so enhanced, again, is thinking of linkage broadly, and then also thinking of the ways that we want to leverage community partnerships to really optimize and enhance our program outcomes. And Bev, you can go to our CBA slide. So who are we? A little bit, we're the Denver Prevention Training Center, and we've been talking with and meeting with all of you, and very impressed, as always, with the hard work that is being done in the community, in the field. As the Denver Prevention Training Center, we're part of capacity building, a capacity building assistance program of services that is for high impact prevention. Our network of services is funded by CDC, and you can see we work in the West. It's the purple on this map, and on the graph we are specifically funded and aligned to be providing services in Track A, clinical HIV testing and prevention for persons with HIV. And the focus of the CBA programs is really on addressing health disparities, addressing social determinants of health, and providing culturally competent and responsive HIV prevention services.
All right, so we're going to do a few introductions. We'll start with ourselves. I'm Bev Wasserman. I use she, her pronouns. I'm the nurse field consultant with the Denver PTC. My background is in HIV clinical care, but the past 10 or so years, I've been doing more training and capacity building work. So I truly enjoy this opportunity to talk about all the services that Julia was mentioning around when we think about the term health navigation services, and how it kind of meets up and intersects with clinical services, and how we make that seamless. What are the strategies we use to help that? So we'd ask you, I'm going to ask Julia to introduce herself, but while she's doing that, if you'd put in the chat box for us your name, your pronouns, if you use those, and your role in your organization, and what's your favorite food. So Julia, you want to share a little bit about yourself?
Yeah, thank you, Bev. I think we were hungry when we put this prompt together, and I always love talking about food, so it fits. We can fit that into any topic. My name's Julia Weise. I use she, her pronouns, and I'm a social worker by background and training, and I've been with our Denver Health Organization and our Prevention Training Center for my whole career, over 30 years. When I first started, Bev was a nurse provider in our infectious disease clinic, and I was the social worker there. So we've been overlapping with one another over the years in lots of ways in the work. And similarly, I've really enjoyed the last number of years being able to do more of this training and consultation, and honestly learn as much from others as we feel like we're able to share and just facilitate that learning together. And so thanks for spending some time today to talk about linkage together. I love linkage. Oh, I should say also, sorry, very relevant to my role, as I, for the last about 15 years, I was overseeing and supervising our linkage care services within our Denver Public Health Department and Safety Net Hospital.
All right, thank you, Julia. So I see we've got a few comments in the chat box. Felipe is Director of HIV and LGBTQ Services, Love Asian and Mediterranean Foods. Wonderful. Terry Stewart, consultant with the Denver PTC, Northern New Mexican food, lots of green chili. All right, Terry. And then Katie is also here with the Denver PTC, doing training in HIV prevention, loves spicy Thai food. Julia said sushi. Let's see here, Lavada is with Impact Exchange, grant manager and loves seafood, and Michelle, HIV linkage coordinator at Track B, HIV prevention and testing and linkage, also harm reduction for over 10 years. So you've got a lot of knowledge in this area we're going to be speaking about. Korean barbecue, that's kind of on my list of something I want to try. I don't think I've ever had Korean barbecue. And then Zami, who is our SIBA manager, collard greens and catfish. Oh, that sounds yummy too. All right, well, thank you all for sharing. Hopefully I didn't miss anyone, but we appreciate just kind of, getting to know each other a little bit, even in this brief time we have together. So before we move on, this is something you can think about it, and you can throw it in the chat box or just consider it as we're moving forward. If there's a focus or a curiosity around linkage to care services or linkage services, either list that in the chat box, or as we're going to have some opportunity to share back and forth. Do tell us, and we'll all explore kind of what you're thinking about when it comes to linkage to care. There may be something specific going on in your program that you'd like to kind of talk about in this space as we talk about these expanded linkage to care services that Julia mentioned. So without further ado, we're going to move on, and Julia's going to, after I share the objectives, we're going to get into the meat of our topic. So today, our hope in this time together is we'll talk about foundations of linkage to care. Again, you all have already been doing this work, so we know some of what we're saying is preaching to the choir, if you will, but we realize we're sharing kind of some of the principles and some ideas of how do we expand linkage to care and look at it broadly, and look at how we create partnerships and all of that. We'll talk a little bit about the Rapid ART Toolkit, because it was really designed and developed with linkage to care in mind. There's a huge section in the toolkit that focuses on linkage services. We'll talk about partnerships and client engagement, and then we'll identify some considerations when you're thinking about prioritized populations, those specific patient groups that you are working with, and how you continue to tailor your linkage to care services. So Julia, I'm going to pass it back to you.
Perfect. Thank you, Bev. Yes, so we're going to start with a definition of linkage to care. Again, as Bev says, you all are in the work. These are not going to be completely new or foreign concepts to you, but we want to set the stage and sort of have a foundation of understanding together. When we're thinking of linkage to care, I know our program in Denver Health has always thought of linkage as a package of services. And so, if linkage to HIV specialty care were as simple as just helping to facilitate scheduling an appointment for a client, or even making that phone call with the person at that time, it's usually not that simple necessarily or straightforward. And so we think about linkage as this suite of services, or a package of services that includes everything that helps guide a person in assimilating, learning that they have HIV through the process of that testing, and learning about living with HIV, having HIV, and then through that process to linkage to specialty HIV medical care services and all the pieces that go along with that, that can include, financial screening and insurance, assessments and referrals for all other sorts of ancillary services, including, substance use support, housing, ongoing case management, etc. So from our program at Denver Health, again, we really thought of linkage in that way then as a process. And so it's not sort of a clean start and finish all of the time, but it's the whole process across the continuum of care. that we're hoping to help achieve that outcome of linking to care, and hopefully have that meaningful and full engagement in care that would even result in being fully virally suppressed. We know that care is prevention, of course, and that's just such a simple and clean message, but something that we really think about and focus our services with our clients. So we want to talk about a couple of foundations that support underneath linkage to care. And one is this, being client-centered. So at its core, linkage to care is a client-centered approach. And this is originally developed from psychologist Carl Rogers, from the belief that every person has an innate tendency to move towards self-actualization. Kind of a lot of big words, but basically that idea that it's just natural that everyone has within themselves that desire and ability to move toward the best version of themselves, fully realizing their potential. And so where we can provide client-centered care and services and linkage, there's a few things we do intentionally to make things client-centered. We start first with the importance of starting where the person is at. So each person is unique. They bring their own lived experience and life circumstances in with them. That's part of who they are. And we want to learn about that and start where the person is. We know that we want to honor that the person is an expert in their own lives. So I am not an expert in Bev's life. I know some things about Bev, and I think she has a fabulous life, but I'm not an expert in her life. I should be an expert, hopefully, in my own life. I don't always feel like that day to day, but that's the idea here is we're leaning on the client that we're working with to tell us about their experience and let them tell us who they are. Our services should be adapted according to prioritized needs that we're hearing from the client. We have information, we have lots of information. We're very often eager to be helpful and be that helper. And so part of our role is providing information, but we want to tailor that again, according to the person we're working with. What is their story? What are we learning and hearing from them? And what's their prioritized need right then, right in that moment? And that's different. It looks very different for everyone that we're talking with and speaking to. I think of just one client example, someone who had just learned they were living with HIV. It was a young MSM of color, 19-year-old person. And at that moment, he was so concerned about his partners and so worried about his partner's status and concerned that his partner needed to be tested. And that was really all I could focus on in the moment. So though Linkage to Care Services wants to, ask questions about insurance, provide information about HIV and about intake labs and where they might go for care, in that moment, being client-centered meant to take a pause, hear that person's experience and start where he is at and focus and talk about first what it is that was up front in that person's mind, their top concern. We also think about, we love acronyms in this work. We think about a term we call what's in it for me, or it's WIFM. So the what's in it for me is really identifying, thinking about what would be a motivating piece for that person that might help them see the importance of linking to care and services. So that's another way that we make things client-centered and individualized to the patient. If someone is very motivated, maybe for some housing resources, and that's a part of the package of linkage services we could provide, or some housing resources, a referral to a housing specialist, that would be a what's in it for me moment where we can help to leverage that motivation, something that's important to them, that they're prioritizing, tied to their own expressed needs, and in that way, hopefully make for a better linkage outcome. So with kind of an introduction from client services, we're going to do a little advanced Zoom clicking here and get you to interact with us a bit. We have this grid here, and we're going to use the annotation feature to select which of these concepts you think align with being client-centered or a client-centered approach. There's multiple favored answers here. To annotate, you can take if you're on a computer, take your mouse and hover at the top. You can click the little view options down arrow at the very top of your screen, select annotate, and then from there it should open a little dialog toolbox for you, maybe at the mine's on the side, yours may be at the top or bottom. And then click the little there's a little check mark that says stamp next to it. From there you can select a shape, it's a star or a heart or a question mark, and go ahead and let's just mark up this slide here. So go ahead and feel free to click on any of the boxes. I think that that are concepts or terms that align with being client-centered or seem like they would be a part of a client-centered approach. Great. I see some clicks happening. If for any reason the annotation is not working for you, feel free to throw a keyword in the chat and we'll read those out as well. Let's just see, give you another couple of seconds here to mark things you think might be related to a client-centered approach. Great. Good, good, good. Okay. I'm going to start reviewing, but I think we're getting the key pieces here. Active listening, absolutely. Being person-centered, of course. Displaying empathy is very important, something that we try to do to build that rapport with clients. Nothing I'm telling client what to do, and that's right. That would not be so aligned with a client-centered approach. Like I said, we have information, of course, we're sharing information, but it's more so making that fit in with what the client's needs are. Meet the client where they're at. Singing is lovely. We like singing. Singing is very, a happy thing, but maybe not client-centered per se. Using the same approach with each client would not be so client-centered. Again, that would be, not as client-centered, not so much taking into consideration what that person uniquely is needing. Being genuine, allowing autonomy, yes, great. And again, recommended ART use for all, but not necessarily aligned for all persons. Okay, that looked like that was easy. Fantastic. We wanted to give you a chance to interact with us a little bit. So we're going to move on to the other foundation around linkage services, which is being strength-based. And thanks, Bev, for managing our slides. So the importance of using a strength-based approach, it ties in super closely with being client-centered as well. We want to be able to highlight every person, again, bringing a unique lived experience. And as such, they have strengths. So even though persons that we're dealing with and talking with, they're bringing in a lot of challenges, trauma often. They may be in a time of crisis when we're meeting with them, but everyone still is bringing strengths. There can be resilience. They found their way to you. They're seeking services. There's many strengths that we can outline and focus on. And that is kind of the foundation of what being strength-based looks like. We want to help the client identify their own strengths. And we found from the artist's linkage model, that's the CDC linkage to care model and strategy that we train, that helping clients identify their own strengths increases their likelihood of linking meaningfully into care and services. And so that is why, part of why that's an important concept. Linkage coordinator can help the client reframe their thinking to focus on what's right and less on what is wrong. And it's hard because unfortunately, often our reflex is to first focus on what's wrong or focus on barriers. But the strengths-based approach asks us to flip that and say, what's going well? Focus on what's going well in place of challenges. Not that we just gloss over challenges or pretend that they're not there. Of course, we're responsive and integrating the challenges that we hear, and that is also being part of strengths-based, but it's just coming from the asset-based approach, in particular, emphasizing the assets versus the challenges. A super simple example is just maybe how we use language. Instead of greeting someone saying, "How are you doing today?" we might say, what has been going well for you? What's something that's good? Or is there something better since we last talked? Those are ways that we just kind of flip our language, adapt our language to be more strength-based. So let's play with another slide. Get ready to annotate. This will be your last opportunity. So again, you can click on the top, select annotate. And then from annotate, click that where it says stamp. It's the little for me is a little check box. And or maybe oh, it's a star now for me because I just chose that last time. So yeah, click whatever you want to do to click onto the slide and select the components here that you think align with being strength-based. Fantastic. Yes, I'm seeing helping clients identify their own strengths. We do discuss barriers they might face. We're focusing on empowerment. We'll encourage clients to be autonomous, to be able to find their own confidence and efficacy around linking to care, learning what they need to access healthcare effectively, supporting healthy life developments. Great, fantastic. Yep, not too many marks on doing things for a client, focusing on losses, or dancing, which again, we might love dancing, but maybe not aligning perfectly with the strength-based approach. Great. Okay. Thank you for that. I'm going to pass along now back to Bev, who's going to walk us through some of our Rapid ART toolkit.
Okay, thanks, Julia. So again, we won't spend a lot of time on this. We have shared, I believe, the entire toolkit with your organizations, but this scan code actually works and will, if you want to pull up your scan option on your phone, feel free to pull it up and look at the section I'm going to be highlighting. We particularly want to draw your attention to the HIV navigation services. And I'll talk a little bit about what we mean by that and how linkage to care is one of the key sections or key roles really within what we call HNS. So again, this toolkit was developed to support clinical programs and linkage to care and community-based programs and pharmacies. So it's really broad reaching as far as the audience for the toolkit, but we really, our team was fortunately part of the team that developed this. It was a national group of CBA providers that we shared with earlier. But again, the goal of this toolkit really was to link back to our national HIV goals, which is to improve health outcomes, reduce disparities, achieve integrated, coordinated care. So again, as we think about these HNS services, it's about all of the different roles, whether it's case management, linkage to care, clinical team, pharmacy. It's about coordinating all of this care so that we basically are seamless, not duplicating efforts, and really getting the best outcomes for our clients and patients. Again, this toolkit was the section on linkage to care is really founded on the idea of cultural humility, which links back to some of the topics that Julia was sharing with us, which is really this lifelong process of self-reflection and self-critique, whereby the individual not only learns about another's culture, but starts with an examination of your own beliefs and cultural identities. So again, understanding ourselves, our own communities we've come from, our own cultural identity helps us, again, listen for and understand that in our patients. The toolkit also really focused on trauma-informed care and thinking about acknowledging the many traumas our clients and patients have experienced, and how can we address and tailor our services with that understanding, knowing that, you know, like being really rigid about appointments, even though we know it's hard to serve everyone when we can't have appointment schedules, being able to be flexible in that space, which for us in clinical spaces has always been a challenge, but it is one of the key ideas when you think about trauma-informed care. And then, of course, lastly, thinking about reducing HIV-related stigma, the prejudice and isolation that can occur with a HIV diagnosis. And again, thinking of linkage to care being one of the key supports that help people get through the diagnosis, the identity related to the diagnosis, and all of those factors. So I'll talk a little bit more about this idea of health navigation services. Again, this is really kind of an umbrella term that describes all of the methods and strategies that we use to support our clients through the journey of HIV diagnosis to hopefully the goal being viral suppression. Again, when we think about this toolkit, really talked about, linkage to care as being part of these H&S services. And again, that there's so many other services that linkage to care interacts with, interfaces with, such as, we think about patient navigation, we think about social work, case managers, health educators. So again, there's all of these folks that, again, we're all kind of working in, hopefully, in concert to care for our patients, and by considering all of our roles and how we work together. And we'll talk a little bit more about that in just a moment. The other thing from the toolkit we just wanted to highlight for you is this is an example of a linkage to care visit protocol. You may or may not have a protocol like this in your program, but this is really meant for you to download it, copy it, and make it your own based on how you work with patients according to the most recent CDC recommendation and guidance. They're really looking at if we can get patients started within a 7-day window, which could be an immediate start the same day, the next day, or it could be up to 7 days. Not that people don't start later than that, but the goal is to really get them virally suppressed as early as possible. So thinking about, what are the activities that need to be done? And again, you may not do all of these activities in your organization, but you could make, a little chart and just kind of sort of list what the visits are and what you do during those visits. So again, we're just sharing this with you as a resource, and it is in the Rapid ART Toolkit. These are some other resources we wanted to share with you. Again, you can make these your own. They're meant to download and copy and use. So again, a client follow-up plan, as well as a non-clinical referral form and a linkage to care referral. So this is also a great way to hand off, say that you're referring patients to another organization or to another role within all of these H&S services. You have a way to kind of document and share information. So, or it may be within your organization that, when you're off work or someone else is picking up a client to work with, you have a way of kind of capturing what's going on currently, what are we doing, what are the needs that they have. So again, these are great resources to download and use from the toolkit. All right, so I'm going to turn it back to Julia. She'll talk a little bit more about partnerships and engagement.
Awesome, great. I love the toolkit. It's really helpful, I think, to have all those resources that you talked about, Bev, and have them as a reference and ways to think about all the various navigation services. So yes, linkage partnerships, we're thinking about how to make partnerships and connections really effective, and through our linkage services and navigation services, it really means, being able to develop and then maintain strong referral relationships with others, with other community partners, again, with a goal to enhance the success of client outcomes. So we're hoping for better services for clients, and also in the process, make our lives easier. If we have better, you know how that is, if we have better folks to refer to that we know we can trust and rely upon and that are going to get things done, that creates better outcomes for our clients, can help people link more rapidly, and generally just make for better services. So the things you see on the slide are how we talk about our program summary to others, so that we can explain, here's what we could provide. We think you could help us in this way at your organization. We're still using some of these counseling or skills of how we interact with each other, using responsive listening techniques when we're talking to partners, potentially to build these effective relationships, and being strength-based still. We think of, I have a couple examples on this. I know for us around the time of COVID, of course, we were really in our linkage program services experiencing delays and backlogs with our partners that are providing long-term Ryan White case management services. And this was basically impeding the opportunity for our clients to link, because often they needed to connect get an intake done with our Ryan White case management services in order to access things they needed to link, like financial screenings and services and things. And so we took this concern to our Ryan White Part A administrators, which was for us, it's our city organization. They administer the Part A grant. And in that way, we were leveraging that partnership to try to help consider what backlogs were in place, what the impact was to community, and ways to kind of work around that. And so that was a pretty effective way to kind of leverage some of our key partnerships and make things better across the line. And it did result in some pretty innovative ideas about how to increase capacity and more staff, and improve even compensation for case managers who are still grossly undercompensated, but it was something they were trying to address. I also think of another kind of just like more direct service example. Our linkage program learned from a very key partner to us, our Harm Reduction Action Center, that they were not comfortable for a time. They were doing some community testing, and if they identified someone either newly or known to be living with HIV, and referring to our services, they had some not great experiences coming into our sexual health clinic with the frontline staff. So they were able to feed back to our linkage program, hey, look, our clients, I came in with the client, our clients and ourselves as staff, we didn't feel like that was, it was a stigmatizing interaction at the front desk. We don't feel comfortable. Our clients don't want to come to you. And so the fact that we had the opportunity to have that conversation, difficult conversation, but to learn about it, that door was open, and it created the opportunity again where we could troubleshoot that. We could talk about what the problems were, try to get to the root of the problem, and create some workarounds and some better process flows so that there was better safety and comfort and reduced stigma for clients coming in who were coming in at a really difficult and vulnerable time. And so that was another example of where our partnerships could be leveraged for better outcomes. And we think about also then knowing our partners up front. So know before you go, or know your community. And there we're thinking about what steps can we take kind of before we're needing to refer folks to organizations. Here we're seeing on the slide several key elements. So building trust, always needed, and keeping staff informed about partner agencies and services. We know that staff, our agency services, grants, funding, protocols can change really rapidly and frequently. And so there we have to sort of keep up to speed on what's happening at our partner organizations, and keep one another internally in your own program informed of what changes that might be. And so keeping a check process in your own protocols was really helpful as a way to make sure you're informing all of your other staff if you learn about a staffing change or a new process, a new intake form, whatever might have changed, to share that back with other key staff. And in that way, we all have the same information going forward. It can make services more efficient, and again, better outcomes for our clients. This is an opportunity, a time also to consider developing memorandums of agreement or memorandums of understanding. Not always fully not needed or necessary, but it can be tremendously helpful if there is a need to more formally kind of write out and delineate, here's what we're good at. This is what we can provide. We'd like to provide. Here's the capacity we have. And also for our community partners to say, these are the things that we're exceptional. We're really, really good at this stuff, and we can provide this for you. And that way we're making sure that we're aligning our services as best possible and avoiding duplication. So these are all the ways that we try to become familiar with our community partners. And then lastly, from here, it's just a little bit more of the pre-work. These are the things that we do a little bit upstream from before we're going to be referring clients, especially if it's a new partnership or we're trying to develop a new partnership. It's going to be important to know both formal practices and informal characteristics. We might be thinking here about formal things like hours of operation. Is the organization taking new intakes? Do they have a rapid ART program? Will there be wait times? What does that look like? And then informal characteristics, probably more important still. Who is this organization or healthcare group? What are they really good at? What is their culture? What's the personality of the staff? Who might we want to connect with the most for a particular prioritized population? You know, if it's young MSM of color, you know, what organizations and agencies just really, really, you know, are in that lane and seamlessly providing culturally responsive services in that way. So those are things we want to know that are more in that informal characteristics bucket. But things can also get in the way of having effective partnerships. We know that there's barriers or challenges, and so just thinking for yourselves, what comes to mind? You can type in the chat a couple of things. We'll give you a second here. What gets in the way for you of establishing effective partner relationships, or what can be a barrier? Anything that is something you found that can get in the way, or it can be a barrier at maintaining or establishing great partner relationships. Give me a second here. Any thoughts with that? Feel free to hit something up in the chat. I can think of a few things for sure. Okay, Terry, thank you. Yeah, serving the same population, sometimes there can be that overlap or even a feeling of competition that comes up for sure. So organizations may be less wanting, yeah, competition and funding that might be less comfortable or easy to collaborate if you're worried that you might but not be meeting grant numbers or deliverables or that sort of thing as effectively if others are doing very, very similar work. So that can be a consideration, maybe a barrier at times. What else comes to mind? You're welcome to come off mute too. We'd love to hear your voice if you like. Type or talk, either way.
When organizations work in silos
Okay.
and they're not willing to partner.
Okay, say a little bit more about that. What does that look like?
So that looks like, say, for instance, if I have an organization, right, and I'm gonna do all of the things instead of referring out for some of the things.
Exactly. Okay, so all of that siloing that can take place. Fantastic. Thank you for that. Anybody else have another one? Okay, this is a good list. And again,
I would just say
not
just
to,
not being aware sometimes of partners you could have, right?
yes.
Yeah, just or we'll talk about this a bit, but just thinking
Yeah.
broadly about partnerships and who that could be. So sometimes you don't know that people are doing a certain activity in their program, like you know they serve community, but oh, I didn't know they were also, you know, they're providing transportation. So again, your patients who are living with HIV are also accessing resources there as well. So that
Yes. Thank you for that, Bev. And that is something that we heard a lot in our assessments with community partners and the conversations we had with all of you is looking for opportunities or wanting opportunities maybe to broaden potential partnerships and think outside of the box, maybe other ways to reach, you know, we may be saturated in our efforts to reach a particular prioritized population. And so where can we go instead that's maybe outside of the usual suspects, usual places that we've focused our services and outreach and testing and communication and marketing? Is there something that might be like one touch off, but still would be key stakeholders who would have connections with the folks that we want to ultimately reach, but get some messaging and outreach and communication and health information, testing information, HIV prevention information to others who could then help bring into services folks that we are hoping most to serve. That's great. All right, great. Thank you for participating a little bit. And Bev's going to talk a bit more about the importance of trustworthiness and partnerships.
All right, so thank you all again for sharing ideas on that topic and thinking about all of these ways we partner and the barriers that can get in the way. One of the things we like to talk about, and this is a little more broad than even our partnerships, as I know you all are well aware of, our patients in our communities have a lot of mistrust and distrust of healthcare systems, healthcare services, and for good reason. It's like the example Julia gave earlier. When people have bad experiences, don't feel like they belong in a space, are not treated with dignity and respect, we not only lose their trust of us, but we lose anybody they would talk to about our services. So, right, word of mouth is very powerful. That I go out and tell a friend, oh, those folks over there are really horrible and they're not very nice. I don't trust them, because you figure if people can't treat you with dignity and respect, they're not going to provide you quality services. So we really, especially for large institutions, it's so important for them to show themselves trustworthy, as opposed to expecting our patients and communities to automatically trust large systems that don't always serve everyone. They're not built to serve everyone, and they don't necessarily attempt to do better. And this is one way for large organizations to really show, well, we're trying to do things different by listening to community, engaging with community, and understanding the needs and hearing feedback, like in Julia's example, hearing that feedback that's not comfortable, but the reality is there's a population of people who can't get to you because you've kind of broken trust with them. So we think that, again, that's again an area where we know that Linkage to Care is that bridge again to help people re-engage with health services. And again, your role to advocate and say, I'm going to bring them to re-engage with you, but things need to be better. They need to be different. They need to be, people should feel better after they leave visiting health service spaces and things like that. The other thing we talk about a lot, again, we think about or larger organizations and again, community organizations as well, is trying to hire staff that reflect the population, especially in leadership. We find, especially in large organizations, that a lot of the frontline staff may be from diverse communities, but leadership tends not to be. So it just lacks kind of that follow through with community voice and representation of here's how we're serving our particular population. So it's one of the things we've done in our health department that we think is really valuable for folks to consider. And then, of course, thinking about this term that we call, we didn't develop it, but Dr. Kimberly Crenshaw developed this term intersectionality, where she talked about, we all hold multiple identities as far as how we represent in society. And sometimes those identities can be overlapping and cause multiple ways where a person can be oppressed. And sometimes one system is not built to deal with all of the different harms that can come from various intersectional identities. So we think about our understanding of this really helps us when we are supporting clients and patients through this process of linkage to care and getting virally suppressed, that we're understanding that if a person is a person of color who is transgender, who is living with HIV, they're holding several identities, again, that can be stigmatized, that can be oppressed. And we're thinking about how can we address and remove some of those barriers to care, address the stigma, those kinds of things. So it's just one of those concepts we like to include when we think about important focus areas for linkage to care. And as well, we think about, I'm sure you all have heard about the social determinants of health. We talk about that a lot. in public health and HIV services and care. And that's really all these social impacts that we have. Can we access housing? Can we get jobs in a region where we can actually get to the job? Do we have access to food, healthy food, those kinds of things? And we think about this is a eco-sociological model that really includes, I like it because it includes culture. It's like all of these different factors impact someone's health, their health outcomes. And the same is true, of course, when we think specifically about our patients who are diagnosed with HIV. All of these other factors are also impacting kind of their ability to link to care, or even their desire, because as we talked about, sometimes there's so much distrust and mistrust from how people are treated when they access certain services. And then we also like to think about community connection. And this is one of those things that, again, Julia, your example hit a lot of points. When you start to ask either community members or other folks, what does the community say about your organization? Or what do patients say to you or clients about your organization? So we'd love to hear from you on some of these questions. Like, have you had direct feedback about your organization? Or sometimes it's kind of just the positive feedback that people keep coming back to you. That's a great piece of feedback to know that means you're trusted, or they send friends. They send someone else who needs the same kind of service to you. So what do you all think about the first question? Do you ever get feedback on kind of what the community feels about, just in general, about your organization? And feel free to chat or unmute. We'd love to hear your voice. Or maybe you do surveys.
Most of our community partners that I had the privilege of speaking with, they really love what we do here because we are a harm reduction organization.
Okay.
And then we also provide the testing.
Mm-hmm,
So the fact that we have Narcan and naloxone is like, oh, we love you guys.
Right.
Our clients, they also give us positive feedback on our surveys that we do.
Okay, that is wonderful to hear. And again, it's what you're offering, you're meeting those community needs. So offering harm reduction, offering naloxone and Narcan just says so much about understanding what your community needs. And then you're offering testing and, of course, linkage services. So it really is very holistic. And again, there's different ways you can get this information back, be it surveys or other methods. Some other things, again, you all don't necessarily have to answer this, but thinking about, as we talked about, representation. Does your team represent the community you're trying to reach? And sometimes we can't always do that 100%. Sometimes there's just not enough people, or we have a limited staff. But we're going to talk about, again, with the partnerships, how we kind of bridge that gap with representation. If, say, we're focusing on women who've acquired HIV, but we don't have any women on staff. So that's just one example of, we can partner with an organization that serves women. Maybe they do other things. Maybe they do chronic disease or other things. So these are just questions really to think about, how you partner, how your organization represents the community. And again, getting that positive feedback on what you're doing and the services you offer. All right, so just a few more items we'll cover, and then we'll stop and have some time for dialogue. But we, again, just as I said, we think about, are there other ways that partnerships can reflect communities? So this is a great example, and I don't know, years back, because I've been doing HIV work for a long time, there used to be a lot of different programs. We used to go out on World AIDS Day here in Colorado, and talk with the owners of the shops, beauty and barber shops, and ask them, would you give out some HIV flyers and condoms and information on World AIDS Day? And they, I never had anyone say no. So it was a great way to, again, for us as a healthcare organization, partner with people who were really touching the communities who were impacted by HIV. So this example we have here as well was funded by CDC. It was called Cut for Life. And again, it was about training the shop owners about HIV and HIV prevention. And that's being done as well. I know in Colorado, our Colorado Black Health Collaborative actually has a program to support chronic disease screening and prevention. So they actually do some screening tests in the shops. They do blood pressures, they do cholesterol screening. And that's when I think about partnerships, that's another way, say you're serving African-American community and you don't have many African-American staff that represent that community. By partnering with an organization like that, again, you kind of broaden your service perspective by partnering with an organization that reflects that community. So Julia, any other examples you have of kind of community partnerships? And then Zami.
I was thinking about some of our testing and outreach team at Denver Health have done some similar, just innovative ways. Again, sort of just that a little bit like one touch off, or one key contact, maybe away from our normal approach of who's serving communities we're hoping to reach. And I know our outreach team has done some work. I think you use the example of some of the cardiovascular screenings, but we've partnered with cardiovascular screening outreach events and offering testing as well as heart screening and health information in those kind of settings at health fairs, also in just university or college settings. So school-based settings have been places, even within our school-based clinics, have been places that we might not like traditionally think about as key partnerships, but could be just one key informant or key stakeholder touch away from the folks that we are hoping to reach, and might be even more effective at reaching folks than our direct efforts at times, because persons that we're maybe intending to reach are prioritized populations depending on funding, may or may not be at the events and venues and things that we're targeting for testing and community services.
All right.
I saw
Zami's hand was up, I think.
Oh, good.
Yeah, I just wanted to give another example. Back when I was doing HIV and Hep C testing, and we needed to get more folks of color to get tested, one of the strategies I did was also go to barbershops, but also go to tattoo parlors. And so even though that folks, the risk of getting HIV is very, very low when it comes to tattoos, using Hep C and Hep C testing as a way to get folks to get tested for HIV, and just saying, oh, I'm already testing you for Hep C. Why not get tested for HIV was a good strategy, and that helped us meet a lot of our numbers. So also going to places that maybe are lower risk for HIV, but higher risk for some of the other STIs that you might be testing for was a way for us to get into the communities that we were having a more difficult time with getting into.
All right, thank you. Those are great examples. Before we kind of summarize the presentation portion, any other examples from Levada or Felipe, Michelle, any examples of kind of community partnership activities you've participated in?
I think in general, our organization, we've participated with like local universities, particularly like with their LGBT resource centers. not only for testing, but also for linkage to care, right? Some of these universities also do testing on site, and they have university medicine, but if there's any like, situation or need for a student who maybe doesn't want to access care through university medicine and wants to come to a community-based organization, we work with them. We work very closely with our local Planned Parenthood as well. So whenever they identify somebody who's positive, they immediately call us, and we facilitate linkage to care to medical care services and case management services on our end. And that's been a very beneficial partnership and a very strong partnership for us in particular.
Great, thank you. Those are great examples. Yeah, any others before we kind of summarize our talk? All right. So we're gonna
Something Felipe said made me think also of something our linkage program at Denver Health hasn't done as strategic a job with, I think, as we could have over time, is we get calls from our linkage services, gets so many inquiries and calls and referrals. And we don't always know where those inquiries are coming from. And I think that's another opportunity, and one we haven't taken advantage of as well as we could, I think, to track where are people hearing about our services potentially. How do they even know to call us? And it's great that it's out there, and for us, we don't mind being sort of a clearinghouse. Even if we're getting inquiries that don't perfectly align with our services exactly, we can point the person in the right direction. But I think that's another kind of a missed opportunity or potential opportunity for tracking, where are people hearing potentially about related services, and that might be a place to then strategically kind of slot in additional touches and ways to meet other similar clients in the future, potential clients, persons who need services.
Great. And Michelle just shared that she worked in an agency that absolutely love tacos. So she said it was a taco truck and did testing for tacos. I'm like, oh man, I would
Yes.
totally there, right? So
oh my gosh.
again, like food brings us together, right? So that's again another great kind of partnership idea where you just meet probably a variety of people, because eating food is universal. So thank you for sharing that, Michelle.
Yeah, I love that. Yeah, thank you, Michelle. Clever name too. And some of these settings there, it's just a lot less intimidating, right? It's just going to be a whole lot more comfortable to be at a taco truck or at your, hair salon, potentially, and have a conversation. It might just feel a little bit more comfortable than going to your identified sexual health clinic, for some people in some way. So yeah, so in summary, we have the care continuum because we think that everything we've talked about today, sort of, we can remember how our services align across the care continuum, and we're offering services and touches at many points across the care continuum. So linkage to care is a part of those group of services, navigation services that can provide support for persons with HIV. The Rapid AR Toolkit really is that, a toolkit. It's full of resources, tips, examples, ways to think about how we're offering services and to improve linkage and navigation types of services. And even if your program is not especially clinical or maybe not aligned currently with a Rapid Start program, a Rapid ART program or services, we're still always looking to shorten the time that it takes somebody to get into the care and services that they need. And so I think the Rapid ART Toolkit does that. It talks about a lot of the clinical pieces and what that looks like to be offering medicines in a faster way, but it also talks about the services and the touches and the navigation that it takes to get there. And that's the piece that we're speaking about today. We know that partnerships enhance linkage services. So linkage, we know it, we're doing it, but where can we better leverage and better reach and touch and simplify what can just be an overwhelming and confusing process of accessing HIV services and related services. And then all the things that Bev shared about intersectionality, intersecting identities, culture. how to be responsive about that and bring cultural humility into the spaces as much as we can, and the impact that that can have on patients. And I mean, for myself over my career, the best I can sometimes do is give an acknowledgement and call out what I know about myself, and sometimes that can help. I'm not going to always look like, as a cisgendered white woman, I am not always going to look like the persons that we're serving. Not any one of us can do that with all the persons we're providing services for. And sometimes just being sort of honest about that and identifying and naming that can, I think, help provide a little bit more comfort to persons that we're working with. It shows that we have some awareness about that and about identity and the importance of identity and culture and background and what that might feel like for somebody to talk with us in a sensitive time, potentially. So that is our summary. We're going to open it up, and we'd love some little more questions and